Thank you very much indeed for coming along to this session. There's a few of you here, but we're really pleased that you are here because we're taking a bit of a diversion from the normal iCAAD presentations with this session this morning. And it's something that we wanted to try at this event because we are quite passionate about drug policy generally. And as you know, iCAAD really focuses a lot on looking at the individual as a person and the way that we can help to treat individuals and the reasons why individuals have the problems that they have. But what we don't do at iCAAD very much is look at a bit of a wider picture about the public health aspects of substances and addiction and mental health. And also how, from a policy point of view, are we responding to that wider picture? And it's not just in the UK, there's very much a global consideration to have. And I think probably many people are aware of the war on drugs and the approaches that different countries across the world has taken to tackle the problems that drugs and alcohol have caused on a wide national public health scale. And I think there's lots of evidence to suggest that some of those approaches haven't been the best approaches to take. And in some cases, they have caused more harm than they have actually solved. And there's lots of discussion to be had around that. We want to bring this discussion to iCAAD, which is why we have this session here. We've assembled the 5 finest minds and don't laugh, it's true. Some of the most passionate people who have an awful lot to say about drug policy, both in the UK and globally. And they're here today to talk to you about that. Now, it is a slightly different subject than the other sessions that you would have been to at iCAAD, but I'd really invite you to listen, to formulate your own opinions and ideas, and also to take the opportunity to ask the experts their opinions, perhaps challenge if you feel you want to challenge, or confirm your own views. Just take the opportunity to do that. It's here for you this morning to do that. We're going to have a very nice, relaxed session. If you want to just call something out, feel free to. No formalities at all. Happy with that? You're laughing, so that must be a good thing, I think, as far as I'm concerned. So I wanted to just do some very quick introductions. I'm not going to read a biog for each of the members because that'll take up half of the session. So just so you know, you can see the biogs in your program, but just so you know who's here. Just to my left here is Dr. Gordon Morse, formerly of Turning Point, and you have various other accolades to your name, don't you? Which perhaps you can say that yourself in a minute, or not, as the case may. I can see you're slightly squirming about that.
No, it's okay.
With that.
I'm not ashamed.
No, I'm not suggesting that at all. And then Dr. Chris Ford, who is from the now the ID. Chris, you say it for me because I can never remember.
International Doctors for Healthier Drug Policies.
Right. Actually, it'd be really good if, before you speak, you can just say a little bit about each of your organisations. That would be great. So, Niamh Eastwood from Release, and you'll introduce what Release is in a second. Naomi Burke Shyne from International Harm Reduction, or Harm Reduction International, is it?
Yep.
That's right, sorry. And Fordham from the
International Drug Policy Consortium.
Yes, great, thank you. I'm doing this all off the top of my head. Clearly that wasn't a good thing. I should have written those down. So here are the speakers. We're just going to go through a succession of very short talks, which will give you a real introduction and flavour to the topic that we're talking about, global drug policy, grounded in human rights, not moral panic, and then we'll open it up to a discussion from there. So I'm going to invite Dr. Chris Ford to begin with. And Chris, you're going to just tell us a little bit about your organisation and what you do, and then you're going to give us some real-life examples of people who have been affected by global drug policy. So, Chris, over to you.
Okay, well, I'm going to misbehave right from the start and actually talk about some people that I know, and then it flows beautifully why we have formed International Doctors for Healthier Drug Policies. Don't be afraid and come into the body of the Kirk, please.
Do you want to move across as we've got plenty of seats? It makes it a little bit easier. You're going to stay there? Yeah. Okay. I can't force you to stay.
Okay, with that in mind, I'd first like to introduce you to Olga. I'm going to tell you some stories. Who is currently 35 years, and I've known for about 5 years. She came to drugs after an abusive childhood and many other problems in her early life. She's a fabulous, sparky woman who is currently really unwell with AIDS, active hepatitis C, and TB. As a doctor, I feel completely helpless. She reminds me, I'm sure many of you in the room remember when HIV first came to the UK, and she reminds me of many patients that I had in the 80s and 90s, that it was, you could give them care and compassion, but there was very little in terms of treatment. But that isn't the case now. So why doesn't Olga have access to these medications? She's been injecting for about 18 years. She was first arrested when she was in her early 20s for having a tiny amount of heroin on her person, and was sent to a labour camp for 5 years. She's been in prison for 3 times since then. How can this be that we're celebrating supposedly an AIDS-free world in this generation? If you look at Africa, I mean, it's absolutely revolutionised. In 10-15 years ago, there were less than 10,000 people on medication. There are now 70% of people who need, in sub-Saharan Africa, who need HIV medication are on it. Why is that? How can we celebrate that? How did they bring about that change in Africa? The advocacy, community mobilisation, better medications, and all of those things. But the most important of those changes was the political will to actually do something. And that's what we need to think about. Now, marginalised groups, and I include transgender, people who sell sex, and people who inject drugs problematically in those marginal groups. In terms of new HIV infections, they are now the largest group in sub-Saharan Africa. But if we go back to Olga, she lives in a place called Volgograd, which I knew vaguely, but it's one of the cities in Russia, and there lies the key. Russia has some of the highest rates of injecting drug use in the world, between 18 and 30%. And of those, between 18 and 31% of them are HIV positive. In cities, in 5 of the big cities in Russia, it's thought to be as high as 71%. If we compare that to the UK, which actually has less than 2%, and about that level in London, how can this be that this is happening? Well, Russia has a drug program that is only around detoxification. You can go into something a bit like a labour camp and have a detoxification, but there is no support during the time you're in detoxification, and there certainly is no there is no support evidence. And we all know that that has an extremely high, if not 100% failure rate. We also know that the evidence base for OST, opiate substitution treatment, is absolutely overwhelming. But in Russia, it is illegal. We've had one member of IDHDP who has been in jail. Fortunately not, because you can get up to 20 years. He didn't get 20 years, but he got a few years. And you can end up, it is completely illegal. And if you look at modelling with OST, needle exchange programs, and antiretroviral treatment, you can actually reduce new infections of HIV by 20 to 63%. Also, it's supported by WHO, UNAIDS, that actually OST and other methods are actually very useful in reducing drug use as well as vulnerability to infections. So the thing that is making Olga ill and other people who inject drugs is not the lack of effective treatment. It is actually drug policy, totally. Secondly, I'd like to introduce Jasmine, who I've been communicating for about a year. She's in her late 50s and lives in Worcester County in Massachusetts in the US. She came to using heroin by a different route. She had chronic pain, and she was well managed on a small dose of opioids from her doctor. Just before she wrote to me, her doctor stopped her prescription with no explanation and said, "You'll be fine without it." Jasmine tried without medication, but was unable, because of both withdrawal symptoms and severe pain, she was unable to manage. And so she was, somebody suggested she should try heroin, and she found it very effective. We all know there's an opiate crisis in the US, and the reasons behind this are incredibly complex, and I don't have time to go into them. But actually, if we changed American policy, that actually we could reduce Jasmine's risk of overdose and death. One thing that they did change, supposedly to help the opioid crisis, about 2 years ago, is they changed the guidelines around how doctors prescribe and how much they can prescribe. So this created an absolute era of fear in the doctors, and actually a lot of people stopped prescribing to people who actually needed them for pain. Whereas there are many, many other things that the US could do in terms of drug policy. They could give increased access to naloxone. They actually underuse OST, and they use it badly. They dramatically underuse buprenorphine, and to get methadone you have to go through 65 hoops. Obviously the opioid epidemic can't be stopped, but it can be vastly improved by actually Mr. Trump getting his finger out and actually doing something that's useful. Just to finish in terms of my stories, just to check that you don't think the UK is exempt from these policy problems, I'd like to briefly mention my friend Sean, who I went to his funeral about 10 days ago. He was 49 years old. He had a long history of drug and alcohol problems, which he managed very well with methadone maintenance, not an enormous dose, and occasionally when things got too bad he would go in for an alcohol detox. Unfortunately, he had a new key worker about 6 months ago who actually said, probably about 8 months ago now, who actually said it's the government policy, you've got to get off methadone. And there is some truth in that, because you all know that there was a UK drug strategy last year which actually was much more based forcing people to have abstinence. Also, the way that drug services get paid is actually about the successful completions, i.e. people getting people off drugs, and also the costing, the amount of money going to drug services has actually been dramatically slashed. So I passionately believe that actually Sean would still be alive if we had a decent drug policy. He was found with a needle in his arm when his tolerance was completely nil, after 8 weeks coming out of the detox. It is a shame. It is a shame. It is a sham. He was killed directly by the UK government. So what do all these stories have in common? Bad drug policy. Drug policy based on opinion. What does Duncan Smith know about drug treatment? Nout. About opinion and ideology. Like in Russia it is ideology and opinion. It does nothing about the evidence. This would not, as a doctor, you would be before the GMC if you actually practiced medicine without an evidence base, and that is what is happening. So we know that actually with increasing globalization, there are increasing health inequalities, and the most vulnerable people are the people who suffer from that. We know from David's mentioned the war on drugs, and actually that punishing people rather than treating people does not work. So we must stop punishing people and never forget how we can use the health agenda to reduce inequality. And I believe the best way to do this is actually by health-based drug policies, not criminal-based, which explains why I will just finish by actually mentioning 2 sentences about IDHDP, which is called International Doctors for Healthier Drug Policies. Our main aim is actually to challenge these ill-conceived, everything drug policy and go for and infringing on human rights that the rest of the audience the rest of the panel are going to talk much more about. We are now 1,500 doctors in over 100 countries. That means over half the world, which I'm rather proud of. So if there are any doctors in the room, I've got an application form, or you can fill in on the net www.idhdp.com. If you aren't a doctor and you'd like to get our newsletter and become a supporter, you can go on the website or give me your details. Thank you. So fight for health-based drug policies rather than criminal-based. Thank you.
Brilliant, thank you, Chris. Thanks, Chris, and that's an amazing way to really put the context on what we're talking about this morning. And your real-life examples there, I think, really serve as a reminder that often in an event like this, we often talk about all the positive things that we can do, and we talk about how we can help people. But what we sometimes don't think about so much is the people who aren't getting the help and the reasons why they're not getting the help. And there's a lot of people who can't access the type of services that we have at iCAAD here for a variety of reasons. And there's lots more that can be done to achieve that. And we're going to delve into that a little bit in a little bit more depth for you now and explain why drug policies in different parts of the world are working or not working. So I'm going to hand over to Naomi from Harm Reduction International, and you're going to talk about the work that your organisation does around harm reduction and on a wider international scale, how drug policy is working in different areas and not in others. So Naomi, over to you.
Thanks, David. So Harm Reduction International is a non-profit organisation that works to reduce the negative health, social and human rights impacts of drug use and of drug policy. Forgive me for looking at my phone, this is where my notes are. So just by way of personal background, I'm a lawyer working very much at a policy level with Harm Reduction International. And so while I once in a former life provided direct legal services to clients who are in difficult situations, I recognise that many people in the room today are, healthcare providers, nurses, social workers, doctors, and I, am respectful of and aware of the fact that you provide services on that ongoing basis. And so this policy level talk comes from quite a different perspective to where you're coming from a day-to-day basis. So as David said, today I'm going to talk a little bit about the global trends in harm reduction and about the intersection between harm reduction and treatment, because I figure that's probably the best match for us as a group. And because we come from these different kind of policy practice perspectives in this room, I thought it would be, obviously with the common ground of caring about the people that we serve, wanting the best for the patients, the clients, the people affected by drug policy, I thought it would be still worth pausing to talk about what we mean when we say harm reduction at Harm Reduction International. Quite a long name, so I might just go down to HRI if that's okay with all of you. So we define harm reduction as the policies, programs and practices that aim to reduce the harms associated with the use of psychoactive drugs in people who are unable or unwilling to stop. And the defining features of this are focused on the prevention of harms associated with the drug use rather than on the prevention of the drug use itself, and the focus on the people. Harm reduction is very much about meeting people where they're at, recognizing that if you connect with that one person on that day, you are there for them that day and you ask them what you can do that day. It's about respecting the dignity, the autonomy and the rights of that person and providing the right interventions, information, support, services as relevant to that person on that day. Particularly when problematic drug use intersects with poverty, which is not rare in any country around the world, harm reduction is very much about human relationships and about connections to health services and connections to support. And that's where we come from when we talk about harm reduction. So we take this approach because we believe in the value of every human life and because it has been proven to effectively reduce the transmission of communicable diseases. And that's that intersection between human rights and public health, which is where we work. And above all, it's 2018, even in 1998, even before that, allowing people to suffer or die from preventable causes is just not an option, and it shouldn't be for us today in the UK. So firstly, to global trends in harm reduction, these interventions that reduce the harms of drug use. So around the world, we see a great increase in recognition, like formal government recognition of drug use in their countries. There are currently 158 countries and territories that report there is injecting drug use in their countries. The Lancet Global Health says there's 179 countries where there's evidence of injecting drug use, depending on how you define country or territory. But basically, it's the majority of countries around the world that are grappling with this in their health policies, in their social policies, and unfortunately more than we'd like in their criminal justice systems. The positive shift in the past decade is now the majority of these countries reporting injecting drug use have harm reduction policies in the national health schemes, in their social schemes, in their, again, it touches on criminal law, and there are harm reduction interventions in place on the ground. And this is a significant shift in policy and practice. Speaking to one of the founding members of Harm Reduction International, Pat O'Hare, who worked up in Liverpool in the 80s and 90s and talked about the news response he received when he first started giving people information about the drugs they were taking. It was seen as absolutely ludicrous, when in actual fact his approach was, I can't stop teenagers experimenting, I want them to stay as healthy as possible and understand the risks, and if that information shifts their decision at all, that's entirely up to that person, but I would prefer my teenagers are safe. And in 20 years that has shifted dramatically. People are much more willing to understand that every human needs to be equipped with that information so they can make their own risk assessment. But even with this positive shift and having reached this mainstream implementation of harm reduction around the world, the coverage of services are insufficient, a little bit like what David touched on. There are more people that need harm reduction interventions and services and support than exist out there. The World Health Organization says for every 100 people who inject drugs, more than 40 of them should be offered methadone or opiate substitution therapy. And that's not the level we're at. Another significant shift globally, which is quite exciting, is a shift in the recognition of the rights and the agency of people who use drugs. So in relation to the rights, I think increasingly we recognize that your choice to use an illicit drugs does not mean you opt out or you forfeit your inherent dignity or your right to health or your right to access any of the government services that should be available to you. And that's pretty significant because there used to be, a straight up and down line. that you're a criminal and so you opt out of everything. And I think that we better recognise the nuance in societies around the world today. I remember speaking to a colleague in Bangkok years ago, and he's like, it just doesn't work. If they're a criminal, they opt out. I said, well, when you're a teenager, I'm sure you stole a chocolate bar once in a while. I said, yes. Did you opt out of your rights forever from that point on? And it's obviously a very different situation stealing a chocolate bar, but it's that idea about the criminal justice system and rights not being completely separate from each other. And then on the point about agency, I think we're much better at recognising the importance of the involvement of people who use drugs and designing appropriate responses to potentially harmful drug use, and about participating in decisions about their health. And I imagine that's something that you see as practitioners every day. And examples of this increased awareness of rights stretch from recognition of rights violations. Obviously, you can see in the news the horrific situation in the Philippines. President Duterte, under the auspices of the war on drugs, has absolutely slaughtered up to 20,000 people in the streets. There are gunmen on motorcycles going around shooting. I heard a commentator say the other day, it's the only country where you can't go out at night anymore because you're afraid of the gunman, and yet people are voting because they believe the country is now safer. And I think that we recognise this is not about drugs. This is not about the war on drugs. This is about impunity and corruption. And yet, this is a shift for us, even to begin to recognise this is a human rights violation under the auspices of the war on drugs. On the agency point, we also recognise that Vancouver is a fantastic example where the political engagement of the drug users on the streets of the Lower East Side completely shifted the political response to drug use, where they opened the first drug consumption room in Vancouver 20 years ago now. And even at a local level, you see doctors electing to use more objective language in their decisions, and this is something that IDHDP comments on, trying to get that non-stigmatizing language to come out. You're not going to make objective scientific progress when you're talking about junkies and addicts and pejorative terms. We need to engage with people like they are, the full humans that they are. Anyway, so Harm Reduction International has been tracking harm reduction interventions around the world for the past 10 years, monitoring where policy and practice are in place in each country. And we measure whether there's the policy in national documents, we measure whether there's needle and syringe programs available in the country, and whether there's opiate substitution therapy available in the country. We measure whether or not there's a drug consumption room, and that's an emerging area. And we also look at the situation in prisons and ask whether needle and syringe programs are available in prisons, and whether opiate substitution therapy is available in prisons. And this is kind of my perfect segue to the next point, this kind of perfect combination, this fantastic area where treatment and harm reduction intersect. Because while methadone, where medically diagnosed, is an appropriate response to drug dependence and is a treatment option for people, in the harm reduction sector, we see it as so much more. Methadone, as initially offered as a daily dose, offers such a critical point of connection for a person who's having a really hard time with drugs. It reduces reliance. It's not unheard of for a person to be taking a methadone treatment and still be purchasing drugs on the street. And so it reduces the reliance on drugs purchased on the street, on the illicit market. And there are a lot of unknowns associated with that, and we all know that. We've read about the US and the UK opioid crisis. It offers a person a little bit more stability in how they're feeling by managing withdrawal symptoms, and that means when a person comes to the choice of whether or not to buy drugs on the street, they're in a better position to assess the risks associated with that, to opt in, to opt out, to decide whether to share injecting equipment is a really big one, and that dramatically reduces the chance of transmission of diseases if people are able to make those choices when they are making a decision around drugs. So basically it allows the person to become more selective about the conditions in which they use drugs. Also in randomized controlled trials, it's quite exciting to find that methadone performs better than drug-free alternatives in terms of client retention. You can't measure both of those things against what their end goal is, because harm reduction is about engagement and supporting the person, and drug-free options are about finishing use of drugs. But in terms of client retention, you can measure them against each other, and you can see that a methadone program does better in that sense. So just to wrap up, methadone is a controlled medicine under the international drug control regime, under international drug policy, and that means it comes with a lot of kind of hurdles for both the doctor and the patient. As Chris talked about, doctors are under a huge amount of pressure in their prescribing decisions now. Patients have commented in various studies. There's a great 2012 study in the UK done by Harris and Rhodes. Talked to patients about how they were using their methadone and how they experienced it. They said they felt stigma in being tied to daily trips to the clinic, and they felt that when they needed to ask for an adjustment to their methadone dose, whether that was down or up, they really encountered a lot of bureaucratic hurdles. The fact is the entire doctor-patient circle is very clouded with the control paradigm that's imported by the International Drug Conventions. And that's a big problem, you know. We impose a whole set of restrictions upon people who use drugs as patients that we don't impose upon any other patient group. You know, when we think about a person dealing with a mental health issue, we don't ask them when they're about to finish. When we think about a diabetic, we don't scold them for taking a chocolate bar on the side. We think about a person dealing with obesity, you know, it's a journey you take with a client as opposed to saying to a client or a patient, this is the end goal, reach it now. And so I suppose I wanted to end with that question. Why have we allowed the unreasonable exceptionalism of the drug control regime to shape the way we engage with this one group of patients in society? Thank you.
Thanks, Naomi. Are we going to attempt to answer that question? That's
email me.
Yeah, exactly. That's well, I mean, that is the question, isn't it? And whether we can answer it, who knows? But I'm just interested to know if there's any comments from the audience at this stage about the harm reduction approach generally, in the way that Naomi's described. Are there people who come from treatment centres in the audience? Is there anybody here? Yes, a couple. And I just wondered what your thoughts were about harm reduction generally. Is this something that you see in your services, or do you give consideration?
I was just volunteering that I'm from the treatment centres. I didn't have a question in mind particularly. I am a member of RDHP, by the way, and have been for many years. My only issue with harm reduction as opposed to evidence-based objectives is I've found that the harm reduction policy keep people locked into the addiction subculture, and it kind of perpetuates itself in that sense, and that's my concern. I understand we need to give people the right to have harm reduction agencies and harm reduction methodologies, but there doesn't seem to be too much difference for them with respect to their relationship with drug use. Yes, it's legal and it's controlled and it's safer, and we're all much happier because they're doing less damage to all of us and perhaps themselves as well. But they still remain contained and locked into the drug-using subculture. And that's my concern or my observation. And I acknowledge that's their choice in a way, and so be it.
When you talk about the addiction subculture, the drug use culture, what exactly do you mean?
I mean that marginalised, stigmatised group or population subgroup who engage in drug use and all its attendant behaviours and issues and ethics and ways of being.
I suppose what leaps to my mind is the conflation between poverty and other social issues and a person's social connections and the drug use. You know, as a culture, we use drugs, you know, whether it's caffeine or alcohol or tobacco or heroin. Obviously, the intersection of poverty and other complex, you know, mental health or social issues does make it difficult for people to change their lifestyles completely. And yet, I would rather that person be connected with other options than being told they must disconnect entirely from, I suppose, the comforts of you know, your familiar and surroundings that, you know, you're most accustomed to.
So I was going to say that the subculture exists though because of the criminal environment in which that country places drug use in. I've been responsible for drug services for a number of years, which have been specialist services which tend to herd drug users into sort of ghettos, if you like, of treatment ghettos. And I absolutely agree with you that you can give people methadone and so forth. You can see the benefits of that, but nonetheless, they're still bouncing around with all their friends, still involved in very similar behaviours to those before they even came into treatment. Some of those people, however, do rather well. They get more stable. We can then send them out to general practice where they're more distant from their drug-using culture, and they just become patients on methadone. They see their doctor, they get a prescription the same way as anybody else maintained for whatever health problem, hypertension or whatever. So, but I would still rather that we didn't have that kind of criminal environment which encourages the very subculture that you're talking about.
But I think I have to also add, as a GP for 30 years, now retired, that actually harm reduction helps people to make as many changes. I don't separate harm reduction from abstinence. Is the perfect harm reduction, isn't it? It's the end of the spectrum. By supporting people, people use less drugs, people are able to make other changes in their life. If you're spending all your time trying to find your medicine, heroin, to help you, you don't have to do that when you're actually unstable. So harm reduction for me is a spectrum, and actually the other word for harm reduction is care and compassion. And actually that people, I've seen hundreds of patients who have actually come to general practice for harm reduction. People have decided to go abstinent. We'll support them to do that. They're on a journey. I don't like this sort of split between, the poor guys that are still in the subculture. People can make changes in their lives.
Can I say something?
Yes, please.
I'm a therapist.
So could you just wait for the mic, just simply because we need to use the mic. I know you can speak loud, but so it picks up on the recording. So.
Can you hear me?
Yeah.
Right. My name's Julia. I've worked in treatment services for over 10 years as counsellor, recovery worker, outreach worker, the whole gamut, frontline. And harm reduction, I agree with you, is a start. It's not the be-all and end-all. And so many therapists, professionals want to keep this split of abstinence versus harm reduction. It shouldn't be like that. It's a different process for different individuals. They've got to think about their benefits, their money, their family, the whole socio-economic. Housing is a major obstacle for people being able to feel stable enough to get through to harm reduction, through to abstinence when they are ready. It's not a case of harm reduction versus abstinence. That's wrong. Harm reduction is a fantastic start for a lot of people that I see. It gives them agency to make decisions that will affect their life further on down the way. And I'd also like to say one more thing. We need to move away from this classification of war on drugs. We need to stop using that strap line or whatever it is. It started with there's Nixon in the States, and it was detrimental. Then it moved up to Reagan. We need to stop using that terminology. Sort of change it to something else or cut it down. We need to chop that because it's a problem internationally across the world.
It's a war on people.
Yes, exactly. Stop the war on drugs. I'm so against it.
Great. I think you've got lots of friends in the room on that respect, but great to hear you say that.
Would you like to join the panel?
Exactly, yeah. We'll just take one more comment. There's going to be lots more opportunities to comment and ask questions, so please keep thinking about those. But we'll take one more comment and then we'll move to...
I've worked in the voluntary sector basically for over 30 years. Before the term harm reduction existed, our job, as workers then, and I'm going to say as psychotherapists as well, is always to look at how do I reduce the harm of my client. That is my job as a therapist and as a human being. And the term came in, harm reduction, and then it related to methadone prescription with the advent of HIV and AIDS and reducing the need to inject. But now it's been chucked into just opiate substitution. Of course, people use lots of other drugs as well, like crystal meth and all the other stuff that's coming in at the moment. So there's also a need to be always reducing harm, and that's our primary purpose. So that's really what is important for me. It's unethical, I think, what's happening at the moment
Quite
in this
so.
country, as well as worldwide. It really makes me very angry and very sad what's happening in this country.
Can I say something about the drug policy?
Of course you can. Of course you can. Yes.
Sorry, I've run operational services and have for about 12 years, and I agree, in 2010, services went too far, where it was very much abstinence or harm reduction, and actually it was pretty much throwing harm reduction out in regards to commissioners' expectations, etc. However, the last drug policy has balanced it up a lot more, but practice actually realigned itself a lot more over the last few years, where I'm, in my service, harm reduction isn't separate as part of your treatment package, and it's part of the core. And so I think it's very easy to put it separate, but actually it's what you're offering, or what you should be offering, I think, as a provider. Anyway, that's just my opinion.
Brilliant. Thank you for that. So, harm reduction, I think that generally there's a feel that harm reduction obviously is what's needed, and then there are elements of that in the UK and around the world. But could we do more? Could we have a change in drug policy to complement that? So I'm going to hand to Niamh from Release. I think you're going to talk a little bit more about potential drug policy change, decriminalisation, etc. So Niamh, over to you.
Thank you very much. Just to say about Release. Release is the UK's centre of expertise on drugs and drug law. We provide expert legal services such as dealing with people's homelessness, getting them secure housing, recognising that poverty is actually the fundamental issue that most of the people that we work with face. And we also provide expert drugs advice. It's the experience of our clients that actually feeds into the policy work that we do, and I will talk a little bit about that work in a moment. But I want to come back to the UK and what's going on here, and I agree completely with you that practice has caught up, that actually drug treatment centres and surprisingly police forces are showing leadership in this country around drug policy, unlike the government, which is absent in leadership on this issue. It is no surprise that in the last 5 years, when we saw the arrival of the 2010 drug strategy and the focus on abstinence as the main goal of treatment, that in that 5 years we have the highest rates of drug-related deaths on record. And that's across all drugs. That's across heroin, cocaine, MDMA deaths. So this is affecting both people who are living in poverty, who are using opiates, heroin and crack cocaine, but also young people who are using MDMA. We've also seen hospital admissions go up significantly in the last 5 years. We also continue to criminalise people for drug use, for possession of drugs in the UK. In the last 20 years, our organisation estimates that 2 million people have ended up with criminal records for possession of drugs. And we ask, who is criminalised? Because you talked about the subculture, the drug-using subculture. I would again come back to that's about poverty, because people from all walks of life use drugs. Every class, people in the House of Commons have used drugs, have admitted to their drug use. You can buy our playing cards with pictures of them outside this room. Boris Johnson was very enthused when asked about it. Last 3 presidents in the US have used drugs. Arguably, if Trump had used drugs, we might be in a better position than we are. So I mean, drug use is ubiquitous, but this subculture that exists that you spoke about is much more linked to poverty. So who is our criminal law used against? It's used against people who live in poverty and people of colour. We know this because our organisation, again, have looked at how drugs are policed in this country. And when we look at stop and search, for example, black people are 9 times more likely to be stopped and searched for drugs, despite government surveys showing very clearly that they use drugs at a lower rate than white people. So that is a racist approach. It is a drug policing, drug laws are used as a form of social control. Not only were we able to look at the levels of racial disparity that exists in the policing of drugs, but we were also able to look at what areas are being policed. And if you look at London and the boroughs of London, it's the areas of deprivation that have the highest intensity of drug policing. And that matters because at the minute with stop and search, for example, 62% of all stop and searches are for drug possession offences. 62%.
So whilst this discussion about knife crime in the capital, which is a really serious and tragic issue, is going on, police forces are choosing operationally to use their resources to go after kids for possession of cannabis. And the damage that a criminal record does to an individual is untold. It affects their education, it affects their life aspirations, it carries stigma with it, it creates an othering. It puts them to a side in society. We blame them for the problems of society. And yet, the Home Office knows that criminalisation of people who use drugs is completely unnecessary. In 2014, they produced a report that compared 12 countries across the globe. Some of them took tougher approaches, such as Sweden and Japan, where they lock up people who use drugs. Some took a much more pragmatic, evidenced, progressive approach, such as Portugal, that adopted decriminalisation, ended criminal sanctions for possession of drugs back in 2001. Uruguay has never criminalised people for possession of drugs or use of drugs. And even more than that, there's more evidence from the Home Office that shows that our drug policy is failing. So the 2017 drug strategy was launched last July to not much fanfare. But hidden in the background was an evaluation of the previous strategy, of the 2010 strategy. And what that evaluation found, and I encourage you all to read it, but Chapter 5 looks at law enforcement. And it found that we spend 1.6 billion on law enforcement every year. And that money, that policy, has little impact on the availability of drugs. That's what the Home Office says, not me. Little impact on the availability of drugs. It describes the market as resilient. Almost sounds like a shareholders report. UNODC report, World Report's not much different. Things are booming in the drugs trade. But it also acknowledges the unintended consequences of law enforcement. It acknowledges, again, the Home Office acknowledges that it creates violence. It increases violence by disrupting and fragmenting the market. That fragmentation of that market, diversification of that market, leads to innovation in the market. That there is a risk of unemployment for those who are incarcerated or end up with criminal records. That there are harms to families, to children who lose their parents to incarceration. So the government recognises all of this negative outcomes and the fact that it's a failed policy. But despite this, they continue to pursue that failed policy. And in fact, they ignore the evidence from other countries that ending criminal sanctions for possession offences has positive outcomes in terms of health, social and economic factors. Again, my organisation, Release, has produced a report. The most recent version is from 2016 that looked at 25 countries across the world that had ended criminal sanctions either for all drugs or just for cannabis. And what we found was drug use didn't go up. And the reason we looked at that factor first is because politicians are obsessed with it. Every time you hear the UK government talking about drug policy in this country, they say drug policy is working, drug use is falling. That's a false presentation of the statistics. It's falling with cannabis. Class A drug use has remained stable. And in fact, we're starting to see increases again. Furthermore, it fails to actually measure what the important metrics are of a drug policy. Drug policy should not be driven by prevalence. It should be driven by saving lives. And when you have drug-related deaths at an all-time high, then you should question what your priorities are for your policy. So the other countries around the world that have done this, as I said, drug use didn't go up, but there was lots of positive factors. Portugal, as I said, adopted this approach in 2001. Not only did they end criminalisation of drug possession offences, but they also invested heavily in harm reduction, treatment and prevention. And in the 17 years since that policy came into force, what we've seen is transmission of HIV drop significantly, AIDS diagnosis drop significantly, injecting drug use dropping, problematic drug use dropping, the numbers in treatment up. Interestingly, if you look at the drug-related deaths statistics for Portugal, last year they reported 6 per million deaths in their population. Ours, in England and Wales, is 66 per million, 11 times that of Portugal. In Scotland, it is 160 per million, 26 times that of Portugal. Then we look at Australia. Australia, 3 states there have adopted non-criminal approaches to possession of cannabis. Every state in Australia has a diversion program. One study compared the outcomes in Western Australia to where they criminalise people for cannabis to South Australia where they don't criminalise people. Not surprisingly, they find that those who are criminalised have more negative outcomes in terms of their accommodation, their employment, and their relationships. More interestingly for me, they were able to evidence that it created that revolving door into the criminal justice system. So we know first contact with the criminal justice system leads to likely recontact. So if you like, drug possession offences are a gateway into the criminal justice system, and it's young people who are the focus of it. And for politicians who don't care about health and social outcomes, there's the economic argument. So California, I mean, the US has been decriminalising cannabis way back. 1976, California decriminalised cannabis possession. They saved $1 billion within 10 years of that policy. Portugal, again, a recent study last year found that they had saved 18% in social costs associated with savings in health costs and savings to the legal system as a result of not prosecuting people for possession of drugs. So in conclusion, the UK government knows that the 1.6 billion spent in enforcement is a waste of money. It's a failed policy. Its own evidence supports that. At the same time, as Chris has mentioned, drug treatment is in crisis. We have seen budget cuts of 37% between 2010 and 2015, a further 14% last year. And when we treat people as criminals rather than human beings, giving them the dignity they deserve, we cannot have an effective treatment system. We cannot seek to remedy the harms that people suffer when we treat them fundamentally as criminals first and foremost. And that's really why we should end criminalising people who use drugs.
Thank you, Niamh. Thank you, Niamh. I'm going to come to the floor in a second, but before I do, I thought this might be a good opportunity to ask Gordon to talk about the treatment of people in the way that you've just, how can we treat people with this policy in place? And Gordon, you represent the treatment sector on this panel. And so what have you seen in your experience about how people are negatively impacted by policy that's in place, and despite wanting to offer all the help and support that we are able to, what have you seen? What's your experience?
Okay, so thank you, David. So as you know, I'm old. I think that's why I'm sitting here. So I've seen.
You're not as old as me.
So I've seen an awful lot of treatment for a long, over 3 decades. I spent half of that time in abstinence-only services, and the latter half I've spent in services which do pretty much everything we're allowed to do in this country. And I just want to kick into the long grass very quickly this wretched, polarised debate between harm reduction and abstinence. These two treatment modalities are not mutually exclusive, as some simpletons would still have us believe. They are in fact mutually dependent. Because if we only had abstinence, if all we had was abstinence, I mean, how recklessly dangerous would that be? If we can't scoop people back, and keep them safe when they fall off the wagon. So we desperately need to have harm reduction, but equally, how philosophically bankrupt would harm reduction only be if patients didn't have the realistic hope that one day they could achieve their independence again? Independence from drugs, independence from treatment systems, independence from fucking doctors. So I think it's absolutely essential that we have the two, and I won't say any more about it. So, and I'm not going to say a huge amount about the harms from drugs because we know what they are. But it's safe to say, I think, that the large proportion of those harms are not the drugs themselves, but the criminal environment in which those drugs are being used. So, for instance, if you were a young person going to a rave or whatever and you wanted to chemically enhance the evening, well, I guess you could use a litre of vodka, or you could go around the back and get a wrap of white powder. You haven't the faintest idea what it is. This stuff is not produced for you by Reckitt Benckiser. It doesn't come with an accurate label. It's, it could have rat poison, it could have anything in it, and you take it as a punt. That is recklessly dangerous, is it not? Similarly, injecting drugs these days, they're full, they're not prepared by ICI or whatever, so they're full of contaminants, they're full of toxins, they're full of bacteria, they're full of viruses. It is recklessly dangerous. And all of those harms would no longer be there if we had a sensible policy around people who use drugs. But I think it goes further, and I'll come to the point which David said now, about the kind of conscious, or more likely, I hope, unconscious or subconscious way that the criminal environment biases, prejudices, treatment systems. Now, doctors' treatment systems should be above making judgments about people, but sadly we're human beings, and some of that rubs off. And the trouble is, when you make something criminal, that implies guilt, it implies shame, it implies that that person should be punished. And some of that creeps through into treatment systems. I wish it didn't, but the fact is I've seen doctors, I've seen GPs with signs on their doors saying, we don't treat drug users here. I've seen people deliberately kept waiting in hospital waiting rooms, in A&E waiting rooms, because I've heard people say, well, he'll be in withdrawal soon and then he'll have to go. That is a deliberate tactic which is used all over the place. And almost universally, if a drug user is admitted to hospital, it's kind of like a mistake. Oh dear, well, we had to first of all exclude a few things, but now we've worked out that that is the reason for this person being here, then off you go, and it's early discharge, and you've missed a golden opportunity to address all sorts of health needs which you can guarantee that person will have been denied for donkey's years. So I'm sad about that, I'm really sad about it, but as I say, human beings being what they are, that is the way it colours treatment systems. Not just that, I mean, I've witnessed the whole-scale deconstruction of quality addiction services in this country over the last 15 years. That comes from up top, that comes from policy. Where else, what other branch of medicine would you allow the, I'm using that word reckless again, the reckless experimentation, if you like, of putting services out to tender, of shutting down the service 1 minute and then restarting it and putting in a new building the next day? And what's more, at the same time, as Niamh has just alluded to, axing a big chunk out of its budget. You know, you only get away with that because it's drug users. They've even done, and I don't think this was accidental, drug treatment in this country has now been pushed out into county halls. There may be good reasons for that. I've yet to see one. But I know jolly well that part of the reason is that poor old county halls were really strapped for cash. They got little old ladies to keep in care homes. They got potholes in the road to fill. They got, you know, children who need to be kept in foster care. These are all really, really important things, but they've got to cope with a reduced budget, so what are they going to cut? Well, it's treatment for skagheads, isn't it? Because nobody cares about them, because they're criminals and they're bad, bad people. So let's move on. We're not talking anymore about harm reduction and abstinence. We're talking about policy, we're talking about criminality, and I want you to understand that this is not a binary discussion. This is not legalise it or keep the status quo of criminality. It is much more nuanced than that. Now, there was a great doctor, an addiction doctor, nearly 30 years ago in this country, a chap called John Marks, who was an addiction psychiatrist up in the north of England, who, in those days, treatment was almost non-existent in this country. He saw heroin users. He thought, well, it seems like you guys need heroin, so let's give you heroin. And he was prescribing heroin for people. And before very long, this was a scandal, and he was drummed out of the country in disgrace. He was an incredibly wise man. I think nowadays he'd be considered a visionary. In those days, he was considered a crank. And he was also a great speaker. And I commend to you two quotes of his from addresses that he made. The first was this: the free market promotes consumption. The black market peddles consumption. It's only regulation that can control consumption. So what he's saying is, take alcohol, take tobacco, we've got those in the hands of the free market at the moment. Diageo and BAT are doing a bang-up job about poisoning as many people as they possibly can with those toxic substances. Heroin and other drugs, which are now criminal, are in the hands of the black market. And they're doing a bang-up job too about making sure that as many people are using that stuff as possibly can. So there has to be a third way, and we have to look at regulation. Not giving it over, not giving heroin to Diageo or BAT, not keeping the status quo. There has to be a third way. So my last comment is this. If I was to say to you that I were to be dreaming of the day when a white powder, a euphoric stimulant, was freely available in Europe, and tens of thousands of people were using it every year. Indeed, middle-class families were taking their 4-year-old children to try it out, and not one single case of safeguarding as a result. You'd think I was mad. And yet, that is happening right now, today. This year, 10,000 people will be more than 10,000 people will be going to various places to experience this stimulant, euphoric white powder. And, you know, I have to say that hospitalizations will result, even the occasional death, and yet it's still going on. Now that is winter sporting, that is skiing.
Skiing.
I'm not being flippant. I am not being flippant. There is no need for anybody to slide down a mountain on planks, okay? Like there is no need for people to use heroin. There's no need for people to eat puffer fish. That's fucking dangerous too. There is no need to go potholing, skydiving or whatever. So what do? Well, we go back to John Marks's second quote, which was this. I equate, this is John Marks speaking now, I equate experimenting with drugs today in the same way as exploring the seven seas in the days of Christopher Columbus. But what did we do to sailors? Did we lock them up in prison? No. We drew charts and we built lighthouses. And that is, you know, we're talking about behaviors. Using drugs is a behavior. Skydiving is a behavior. Human beings do stuff, and behaviors have positive and negative consequences. As long as they don't impinge on anybody else's human rights, then people should be free to do whatever they like, but we need to be able to show them how to do it safely. When you go skiing, you get lessons, you get a hat, you get police which are groomed, you get markers, you get patrol wardens, all of those things. We're not talking about just giving these drugs to the free market or keeping them criminal. We're talking about doing it in the safest possible way.
Brilliant, Gordon. Thank you so much. I want to open up to the floor now. Is there anybody with any comments about what Gordon and Niamh and the rest of the panel have said already? Quite provocative things there. And I'm actually quite interested if it's challenged anybody's thought processes about drugs and the way that drugs should be approached from a political point of view. So, any comments from the floor? Or stony silence, which means yes, please. As long as you have a mic first, you can do that.
The thing that struck me about what you said about regulation, I'm sort of swayed towards that. I've worked in drug treatment services myself, and I've seen the damage that drugs can do if they are, as you say, impure. So, rather like you have oil refineries, and you have Western companies come in, refine the oil and put it onto the market, you would have the cartels owning cocaine fields in Colombia, for instance, the heroin fields in Afghanistan. You'd have Western countries coming in and processing that. How would you then negotiate with those, they're described as warlords in Afghanistan, and they're described as cartels in Colombia. Is my question making sense there? How would we then, as it were, legalise those people who've got the control of the source of the drug?
Well, we don't have to be feathering the nests of cartels. I mean, hospitals in this country at the moment are supplying heroin to people for, you know, when they have heart attacks or whatever else. That stuff is farmed legally, it's under license, you know. And I have to say, licensing, not that I'm here to defend governments, but I mean, the vast amounts of money, revenue, which can be got from proper regulation and licensing. You know, I mean, we've seen what's happened in various American states. You know, whole educational programs, you know, have been funded by simply licensing some pot shops, which is fantastic, isn't it? All sorts of good can come from this. It doesn't all have to be bad. So, no, do I think we should be going to these guys who chop people's heads off and trying to strike a nice financial deal with them? No. I'd like to put them out of business. They're very unpleasant people. But that doesn't mean to say that that some people can't produce it in a nice, safe way and be rewarded properly. Look at Afghanistan. You know, the bulk of the war, the real war going on in Afghanistan, is funded.
Exactly my point, yeah.
Yeah, exactly. Well, you know, why shouldn't we actually be going to those same farms and saying we need that heroin? But instead of that nasty free base heroin which doesn't dissolve, so people have got to mix it up with citric acid and fry their veins, we'd like you to make nice diamorphine hydrochloride, please. We'll show you how to do it. It dissolves nicely, you know, and then we'll regulate the amount that comes into the UK.
And that was my comparison with the oil refineries.
Yeah.
It would be their resource rather than us
Yeah.
as Western countries growing it over here and taking away any income that they might have from it. Yeah?
So my flippancy, and I have been flippant, and I'm sorry, but it's just for the sake of making a point. It is not an easy argument. There are all sorts of things that need to be thought through very, very carefully, and there are also lots and lots of solutions which won't be free from problems or free from harm. But in terms of being less, absolutely, we can enormously improve on the current status quo.
And you bring up a really good point. I mean, it's a real challenge within the drug policy sector at the moment when we're starting to see regulation of cannabis, for instance, is there are communities like the farmers, not the cartels, but those farmers that you refer to, who are dependent on that income, who, if they lose access to that income, their lives will, which are already incredibly hard, will become much tougher. So I think there is a discussion that needs to be had about how do you responsibly regulate, both in terms of meeting public health needs, but also in terms of meeting development needs and bringing farmers into that market. So I think it's a really live and interesting discussion at the moment. And in the US, for example, we're seeing some of the states like California bringing in taxation that will benefit communities who had suffered directly as a result of the war on drugs. Sorry, Julie. But that's, you know, so communities, black communities and Hispanic communities who have been subject to mass incarceration. Taxes that are derived from the cannabis market there will be brought back into those communities, which is a positive thing, and it's positive to see those conversations starting to happen in the US, and hopefully will feed out into other regulatory models as eventually it will change.
You actually expressed one of my concerns was what would happen to the actual farmers in those countries. They'd have been, if we start growing it ourselves, then they'll just be abandoned. They'll lose a source of income.
But I think that's a bigger conversation about globalization and capitalism, really, isn't it?
Question just over here. Yes,
I don't know if anybody else is here from the U.S., but I am. I flew in from Nashville, Tennessee, where I'm a doctor who treats opiate addiction. Been doing it for the last 6 years. And my waiting room is overran. I'm not joking. There have been days I've been up to 40 patients. I tell my nurse, lock the door, we run out the back. I'm tired, I got to go home. Okay. What has helped change the drug policy, I'm a little bit older when I look, since the 80s, is that yes, they were chasing young black men through the ghettos. My waiting room is 98% Caucasian, okay? They're coming from the rural communities of Tennessee. I'm treating also the upper levels, okay? I'm treating the children of doctors, of federal judges, okay? I think they come to me because they feel like where my clinic is located and the social circles they are in, I'm not in, so they don't have to worry about it getting out, okay? And thank goodness I've had only one death in 6 years from an overdose because I'm doing, okay, the harm reduction, okay? We work towards abstinence. Some people can make it there, some can't. I don't, that's not my battle. I don't worry about that. But I wish 20 years ago, 30 years ago, I think if the attitudes had been different about addiction, you know, my mom always said, God don't like ugly. I think that hen came back to roost on, okay? Even the Nashville mayor last year, her son was found dead from an overdose, okay? The mayor of Nashville. And because some very powerful people have walked into their back bedrooms and their children are dead, okay? They're starting to see, maybe we did this wrong. We over-police certain areas, but other areas we kind of left alone. And now you're starting to see all of a sudden Newt Gingrich, even Hillary Clinton and the Clintons, who say, you know, we got it wrong. you know, this war, whatever it was, never did treatment, just locked them up. And that's why the prison population in the United States just went out the roof. Yeah, yeah, she works with the prison population.
Psychiatry and I write medical policies.
Yeah, me and her actually, which is weird, we've known each other since we've been 18, but we both went into medicine. In different ways, psychiatry versus me doing the treatment. Yeah, she's like state of Indiana.
That's what I wanted to talk about. I am a forensic psychiatrist, and I also serve on our medical licensing board. And part of what we do, our former governor was Mike Pence, who's now our vice president. But starting in 2014, we rewrote our opioid laws. We did opioid abuse and deterrent, and I oversaw that rewriting of the policies. And then this past year, we finally instituted pill counts and limitations and things like that. It took us forever. But before Mike Pence went into vice presidency, the whole thing was to clean up our opioid, because we have a huge opioid heroin problem, obviously, in the United States. But again, being a forensic psychiatrist and being of our state in healthcare, and now working at a U.S. level, working with like we have a medical licensing exam that we do 3 parts of. I'm now part of that board, and so doing more on a U.S. level. So what we're doing now is finally fixing some of the problems. We have recently instituted policies using the bridge. I don't know if any of you know about the bridge for opioid detox. It's a new device, FDA approved in November of last year, but we are now using the bridge along with medical assisted treatment, county by county, going to the jails, the judges saying, hey, if you will allow us to treat your opioid addicts but offer them a reduced sentence, you know, everybody wins. And so we're making small headways, but that is our new, because of the huge opioid problem we have in the United States, what we are now doing, and we have representatives working in Tennessee. And so what we're doing, we're going into the criminal environment saying, we have a huge opioid problem. Let us treat the addicts, let us detox them, because the detox is the terrible thing that people don't want to go through. Use the bridge, 5 days later, you're free of your, you know, pains and aches, and now you can do medical assistant treatment, which also, I'm forensic psychiatry, so I said they need counseling, and so we are doing that now. We're offering counseling, and all of this is taken care of. All you have to do is accept the program, and you get a reduced sentence. So far so good. Wish us luck, because we've got a huge battle ahead of us. And again, we are making our way to Tennessee. So, and I'm sure I have an in there that will help me.
Fantastic. Does anybody want to respond to that at all? Or we do. Yes, I'm conscious, and Anne has been extremely patient at the end of the row. Just dropped the pen at the same time. We will come back to you, but we'll just introduce Anne first. And the IDPC have been doing a huge amount to try to rectify these things, and you're campaigning on behalf of these changes. So, Anne, please tell us a little bit more about that.
Thank you. Thanks, David, and thanks for the invitation to be here and speak to all of you. It's not the usual audience that I tend to speak to. I'm usually working with policymakers. So it's really a privilege to be here and to hear your perspectives as well. I'll be sort of taking more of a bird's eye view, I think, and broadening the discussion out beyond the very specific issues around simply just drug use and drug consumption. I should introduce IDPC. So the International Drug Policy Consortium, we're a global network, 175 member organizations from over 65 countries around the world. IDPC was set up 12 years ago with the idea that all of our member organizations come together to promote drug policies that are based on the principles of human rights, of human development, of peace, security, public health, ideally the broader goals of the United Nations. Because if you check closely, drug control is not a pillar of the United Nations, but human rights is, and that's important. So our members as well make up people who work in providing services, harm reduction treatment services, do advocacy for harm reduction, work in criminal justice reform, work in the development sector, work in peace building, and also work directly with some of the farmers that we talked about, farmers who are mostly working at a subsistence level, farming crops deemed for the illicit market. And we have this whole spectrum of membership because there are, as Niamh alluded to earlier, many, many people all over the world, mostly who are poor, vulnerable and marginalised already, who have borne the brunt of these very punitive policies related to drug use, but not only drug use, production, trade and trafficking of drugs. And that's resulted in a massive human rights situation across the drug market, not just relating to public health issues that we've mentioned already, the HIV epidemic amongst people who inject drugs, but also issues of mass incarceration around the world. Our global prison population is only growing. Women are the fastest growing prison population in most parts of the world, and overwhelmingly for non-violent, low-level drug offences. And why is that? Because women face specific economic vulnerabilities that basically encourage their engagement in illicit economies where they cannot engage as meaningfully in illicit economy, for example. So that's sort of IDPC's perspective. We also, as the Secretariat, which we're a very small team to manage this global network, 5 staff in London, 2 staff based in Bangkok, Thailand. We produce publications and policy analysis to support the discussion. We work with our member organisations to help them generate discussion and debate at the national level, engage with their governments. But we also engage directly with government officials to give input and advice. More specifically, we work a lot at the United Nations, and we get a lot of questions as to why we focus so much at the UN. But I think it's important for this discussion to contextualize the debate. How is global drug policy formulated, determined, and where does it come from? And actually, you know, it's important to think about that because the global regime for drug control does exert quite a lot of normative pressure at the national level. If you look into national laws and policies on drugs, they almost uniformly follow the international drug control treaties, of which there are 3, that basically guide how drugs are to be controlled at the national level. So there are 3 UN drug conventions. You'll be pleased to know that I will not outline them in detail, but it's good for you to know that they are there. Attached to the first 2 conventions is a list of schedules, of which include the drugs that are under international control. The first of the 3 is the 1961 convention, which brought under international control essentially the plant-based traditional substances such as opium, coca leaf, and cannabis. And then the 71 convention then dealt with more, I've lost my train of thought. They're not the plant-based drugs, but they're derivatives, essentially. Pharmaceutical type substances. And then the 88 convention actually encouraged governments to increase criminal penalties for all the activities associated with the drug market. So the 88 convention really ramped up the so-called war on drugs. I hope I can preface it with so-called, because that's how we tend to use it. But we're taking back the term, if you like. So within the treaties, I think it's also important to note that there is some flexibility despite this punitive thrust. So, for example, the ability to remove criminal penalties from drug use and possession for personal use is a flexibility that has been long established within the drug control treaties. So countries can now immediately move towards decriminalisation, for example, without having to look at their international legal obligations. The limit really is, and we can talk a bit more about that, the legal regulation aspect. It's clear, and many international scholars looking at the treaties are very clear on this, that legal regulation for non-medical and non-scientific use of drugs under international control is beyond the scope of the treaties. The treaties were set up with a dual purpose, in fact, which we also haven't mentioned. One is to limit the use of these substances to medical and scientific purposes, but the other goal was to ensure their availability for the relief of pain and suffering. And that's, say, morphine for pain medication. Actually, there's a global epidemic of pain in lower income countries in particular, because the regulations on substances like morphine have been too tight, and doctors are unwilling to stock substances like morphine and to prescribe them for fear of addiction. But it actually has meant that in many parts of the developing world, people are in a great deal of pain where there's no need for them to be because we have the medicines available. I just thought it was important to mention that. So in terms of how the policy debate is shaped, you have those conventions, but governments meet regularly at the UN to discuss progress that they're making on international drug control. The current global agreement on drugs is the 2009 Political Declaration Plan. It ends next year. It has these targets to within 10 years, so between 2009 and 2019, to significantly reduce or eradicate the global drug trade. So they've got about, 8 months left. How do you think they're doing? The UNODC, as Niamh alluded to earlier, the UN Office of Drugs and Crime produces an annual report. In their latest report, the 2017 report, one of the key headlines in that report was, "The drug market is thriving," and I quote. So we're unclear as to how governments are going to approach this deadline. And actually, they have not yet been able to agree a process of review against the 2009 goals, arguably because the answer is obvious, and there's no real need to discuss that. But this does create a specific opportunity that we're in right now. The last big debate on drugs happened quite recently in 2016. Some of you may have heard about the UN General Assembly Special Session, or the UNGAS. And that actually was called for by Latin American governments, Colombia, Mexico, and Guatemala. And we've talked here a lot about the problems that people who use drugs face, but as I mentioned, there are so many other people caught up in this regime of punitive prohibition. And in Latin America, many of those countries have really faced some of the sharpest edges of this approach. So massive violence, insecurity, corruption, mass incarceration. And these policy harms essentially can no longer be justified because, in essence, the drug market is thriving, right? These policies have not had the desired impact in terms of trying to reduce the scale of the market, which was their ultimate objective. So as we approach this moment in 2019, it's unclear at the moment what governments will go to the UN and agree as the blueprint for moving forward beyond 2019. But interestingly, there is very little agreement. So this idea of a global consensus on how we manage drugs that existed for some time amongst governments, that consensus is no more. It's clear that many governments are taking on board the fact that punitive prohibition has failed. They need to look at decriminalisation. We talk about harm reduction here. It's a very sort of global north or UK-based discussion because there are parts of the world where you still cannot even talk about harm reduction. It's not accepted that it's possible to provide people with services to keep them alive while they continue to use drugs in the hope that they may recover one day. That those services don't exist. There's no needle and syringe programming. There's no opiate substitution treatment, for example. So that still, at the global level, is a discussion that we keep needing to push. And in the background to this, of course, you've alluded to, is cannabis regulation, or the regulation of substances, and we've seen already initiatives mostly focused on cannabis. That's, I think, going to provide sort of an interesting backdrop to the whole discussion. In just a few weeks, in fact, it's pretty close now, 1 month from now, the World Health Organization will for the first time review cannabis as to its therapeutic usefulness. That has never happened in history. So that will also be interesting, and the World Health Organization may recommend rescheduling of cannabis from the current strictest schedule that it's in. It sits next to heroin and cocaine, and into a lesser schedule in terms of its restrictions. So I think I'll leave it there just to say, that the debate at the global level is increasingly polarized and fractured. I think that creates opportunities. There will be more progressive approaches that some countries will take, for example, Canada with their cannabis regulation, and also rolling out drug consumption rooms or /safe injection sites across the country to reduce overdose deaths. But then you'll also have, like the case of the Philippines that we already spoke about earlier, some countries probably going in a more harsh and more problematic direction too. So it's great that we're having this discussion here. I think it's important for all of us to be informed, to understand the structural contexts in which we work, and I think it's great that you're here listening to this policy discussion because you're really the practitioners, but I think it's great to have that policy overview as well. Please join the movement for reform if you want to. We lead a campaign called Support Don't Punish. We have a global day of action every day on the 26th of June, which is also the UN Day against illicit drug trafficking and drug abuse, but we're trying to reclaim the message of that day to make it more about reforming damaging and disastrous policies. Thank you very much.
Thank you, Anne. Thank you, Anne. We're coming very rapidly towards the end of our time that we have, but I did promise that we would. Did you still have a comment to make or a question very quickly? Sorry, yes.
So hi, I'm Heather. I'm an American psychologist. I was trained in the US, but I live here in the UK, and I've been here for about 5 years now. I do a combination of NHS and private work. But when I was in the US, I suppose it was 10 years ago now, it was 2007 to 2009, where I was part of a court recovery program that provided an alternative to incarceration for opiate addicts specifically. But they used, and it was really successful because it was a huge reduction in recidivism. A lot of people that were hardcore heroin users that got clean and really changed their life. And there was a lot of poverty, there was a lot of other issues, but it was a wonderful program to be a part of, and I think it was one of the first ones, and it was in the Boston area of the U.S. But they used, their treatment modality wasn't methadone, it was something called Suboxone. And I've been living here for a while, and I've been very curious because I think they use Subutex.
Yeah.
They don't, it's similar, but I think Suboxone has naltrexone in it, which Subutex doesn't, and you can't abuse it in quite the same way. Exactly. So I was curious, maybe it's more of a question. It's something I have been curious about, but haven't quite gotten an answer, and I'm not sure if it's appropriate for this panel. But why that wasn't used and more use here? It was just at a cost.
I think that's a great question, and we've got a very short amount of time to answer. But Gordon, Gordon or Chris, I wonder if you want to.
I'm afraid I couldn't hear it.
Well, it was about why the question is experience in American treatment is that Suboxone is much more popular over there than it is over here. We seem to prefer using the same drug but without the naloxone inside it. I have an opinion about it. I think I've already shot my mouth off too much today. But
I'm happy to add.
It's very clear why it is, because actually when buprenorphine was introduced in the States, they wouldn't let buprenorphine by itself be introduced. In fact, I spoke many years ago with the king of methadone, Bob Newman, I don't know if you know him, and he was one of the first people to introduce it. And I was thinking, why is this conference 3.5 days long? I'm speaking on the first day, I felt and then what's going to happen to the other 2.5 days? The other 2.5 days were around legalization, around regulation, around doctors getting it. It's much more difficult to get in. So you can't prescribe buprenorphine, whereas we got buprenorphine first in the UK and we liked it, and we thought, why the hell do you want to give anybody an extra drug that you don't actually need? So purely because of that.
I think there's also issues with drug courts in the US. If we're going to be frank about it, it's judges who are trained in the law making medical decisions, and I am concerned about the human rights and health rights of people who are given medications that act as complete blockers.
It wasn't the judge that decided. There were people that it was an alternative to them, so they were part of a court. They were part of a court recovery program, so they could opt into having treatment. And it was part of it. The whole program was individual therapy, group therapy, and medical management of their opiate addiction.
And what happened if they opted out?
That they would be more closely monitored by the courts. So they would still be involved, but they wouldn't have the treatment options. I'm not quite sure actually if they were probably had a harsher, I think that they weren't given as much leniency. I think there was some consequence to them not
It aggravated their sentence if they didn't.
Well, I'm not sure, that's a good question. I'm not quite sure what the answer is, but I think it was somewhat something that they could choose to engage in or not.
I think, there's really great, interesting research here comparing the outcomes of people who have been mandated into treatment with courts and those who have gone voluntary. And actually, the outcomes for people who go voluntary are much better than mandated. And again, I just come back to the point that it's not really for the criminal justice system to make treatment decisions. And particularly in the US at the minute, there's a implant, and I can't remember the name of it. What's it called? Vivitrol. which it completely blocks the effects of opioids. So if someone's in an accident, they can't use pain-relieving medication, and people have been ripping it out and things. So there's a problem here, and the only research on it is done by the company who provide it, who say it's brilliant.
So
it's
revolution with abstinence as opposed to the other reasonable treatment options like buprenorphine or methadone.
Yeah. So I just think health doesn't really belong in drug courts for people who use drugs, who've committed possession offences.
Thanks so much. And sadly, we've run out of time, really. And it's great to hear there's been so much interest in this topic. And in a minute, I'm going to ask you just to show your appreciation to all the panelists for giving up their valuable time. But just before I do, just to mention, there's more sessions on the agenda today that continue this topic, and if you're interested, I'd encourage you to attend those sessions. The next one in this room is about medicalised marijuana, and we'll talk about how that could be potentially beneficial in a therapeutic way, and also where we are in terms of making that a possibility in the UK and where it's been done elsewhere in the world. So if you're interested, strongly advise you to come back to this room after the tea break. I've got to give my personal thanks to each of the panel members today. You've been amazing. Thank you so much for giving up your valuable time this morning, and I think it's been a really useful discussion. Please could I ask the audience to show your appreciation in the same way.
Thank you.